Thanks very, very much, Rosaleen. I was thinking, how the hell do you follow that film? It was so humbling, so beautiful. And thank you to everyone. Thanks especially to, as I call her, the force of nature that is Rosaleen Callahan, without whom I wouldn't be here today. So thank you very, very much, Rosaleen, for asking me. So I'm here really to give you a bit of a background as to why I see so many patients, or why sort of amyloidosis is very high up on my list of potential diagnoses whenever patients present to me in cardiology in Altnagelvin. Oh, there we go. So I was mindful that I was the first speaker today, but a lot of this in the first slide's already been covered in the film. But it's just to explain that amyloidosis is, in a very simple way, your body's producing an abnormal protein and putting it into the... It has nowhere to store it, so it puts it into the other organs. And there are two main types that we see in Ulster, in the northwest. AL amyloid, where the plasma cells, your bone marrow is making the abnormal protein, and TTR amyloid, which is what we're talking about today. And again, there are two types of TTR amyloid. There's the variant type, which is the genetic type that we're talking about today, and then there's wild type, which tends to occur more in older male patients, not exclusively, but more commonly, and it's not genetic, it's not inherited. What is TTR? TTR stands for transport of thyroxine and retinol. So thyroxine is your thyroid hormone and retinol is vitamin A. So in its normal form, TTR comes in a tetramer. There's four parts to it. But in amyloidosis, the four parts break up and you get one part that then doesn't know what to do with itself. It's not working normally and it starts to aggregate together. And then that's where you get your fibrils that Rosaleen was talking about in the film. They have to go somewhere, and your body starts to put them mainly into the heart, the liver, the gut. Emer was talking about her mum having problems with the autonomic problems with the diarrhea especially. So that's why that happens, and into the nerves. So you get your tingling in your hands and feet and problems with your walking. There are multiple genetic variants, as Rosaleen's already said, but in the UK Caucasian population, T60A that we're talking about today accounts for about 50% of the cases. And certainly where I work in Altnagelvin, it accounts for virtually all the cases. It's so common. It's certainly the most common cause that I pick up whenever I'm investigating people. And it's about, as we said, it's about 50% of the cases in the UK. And the clinical manifestations of TTR amyloid depend on the genetics. And we've got Professor Riley and everybody here who will talk about this in more detail. But T60A, you tend to get autonomic symptoms, cardiac symptoms, and neurological symptoms with your pins and needles. So a brief history. Not so much a brief history of basically about why I see so much amyloid in Derry, or why it's so common there. Just to point out, when I was a trainee in cardiology in Belfast, I met one patient in the 10 years that I was training with cardiac amyloidosis in Belfast. I came to Derry, and I think it might have been my second weekend on call, and a patient came in who had heart blocks, so his heart electrics weren't working normally. And I was like, gosh, your heart electrics are slowing down, we might need to think about a pacemaker. And the patient was like, oh, that'll be because of my amyloid. Of course, this was in the pre-electronic, there was no ECR, no electronic record. And I was like, scrobbling through the notes, you've got amyloidosis? Yes, I go to London every 6 months, every year. No, there was no letters, there was nothing, but the patient was able to fill me in. He got his pacemaker, he's still with us, he's still attending me, and he's doing great. But just to, that set me on my journey of what is going on here, and then from there I've seen so many other patients with this condition. So Donegal, as all of you, many Irish speakers here. I used to be an Irish speaker. I'm a lapsed Irish speaker, but Donegal comes from Donegal, which means fort of the foreigners. Of course, in Donegal we don't call it Donegal; it's called Chúirt, which is the land of Conall. And we know that Conall was one of the high kings, or one of the kings in the early modern era, and he was the son of Niall of the 9 hostages. Other sons include Owen McNeill, and I'm not a Derry girl, I'm a Derry blow-in. I'm from Tyrone, so I'm from Chúirt Owen, which is the land of Owen, where we don't see so much amyloid. So this has then led to the conclusion that the T60A must have come somewhere from Connell's lineage. Now, was it Connell himself? Was it some of the? I'm sure the man had goodness knows how many wives and how many children. We just don't know. It's all hearsay. But we know it must have come from that lineage rather than Owen's lineage because of the lack of or reduction in cases in Tyrone. Niall was the first nobleman apparently baptised by St Patrick, and as I said, the T60A is attributed somewhere in Connell's line. And Grainan has featured heavily in the film already there. We know that there's a small cluster of T60A cases around Burt. So that led me to the conclusion that maybe Connell was visiting Owen in his castle, and maybe were having a very good time, and there was some genetic spreadage around Burt by somebody in Connell's lineage anyway. But who would blame him, sure? And Grainan's lovely. It's a lovely part of the world. And I was saying to Professor Riley's here, and I was saying to her little caveat of the genetics will probably appear in nearly everyone's talk today. But it's just, we're so grateful to Mary and her team and to Prof. Staunton and everybody for highlighting this, that, actually bringing this together and making, everyone was like, oh, there's lots of amyloid, but it was really trying to bring it together to know, this is why we're seeing this. So T60A, I'm making a plea today, and I'll be on Twitter most of the day, #Amyloidosis Ireland, that we change this from the Appalachian variant to the Donegal variant, because it's not the Appalachian variant. It's only the Appalachian variant because people from this area went to the eastern seaboard in America and spread their genetics, but it all comes, as the Yanks call it, the Scotch-Irish. We're all linked together, I suppose. From if you could fit Northern Ireland and Ulster into one wee tiny state in America, so you can't blame them for that. But the prevalence of another interesting fact when I was researching this about the Appalachian variant. I don't know if any of you are into your audiobooks, but I love some of the audiobooks, and there's one at the minute about derivations of words and terminology, and the Scotch-Irish, as the Americans call them, who went to the Rockies and the Appalachians. Obviously, I was looking at, they probably had similar skin tone to myself, which is not really white, more of a bluish white most of the time. And they went then to work in the high mountains with, and they got sunburn. And where did they get sunburn? Back of their necks. So they became known as the rednecks. And also, some of the Ulster end of that variant liked their sashes and their marches, so they became known as the hillbillies because they were supporters of King William. So it's really, really interesting how things pass into folklore and how they pass into language. But I digress, apologies. The prevalence, about 1% from Professor Riley's studies of the population over 45 should carry this gene, with a penetrance of 80%, which gave us an estimation of about 180 cases at that time. That would the Thaus register, which looked at how likely any country was to have amyloidosis, says we should have about 18 cases. Obviously, that's a gross underestimation, but that's because this area has such a high genetic prevalence. So this is just a map just to show. I work in the Western Trust, so we straddle the whole eastern border of Donegal. We have centres in Derry, in Omagh and in Enniskillen. We see very, very little amyloidosis in Omagh. We see very little amyloidosis in Fermanagh, but we see nearly all of the cases in Derry. And that then was like, well, obviously we know that there's a geographical link between Donegal and Derry. But when you look into it, it's much, much more than that. And there are really, there are multiple waves of emigration from Donegal into Derry, but there are sort of three Derry was the embarkation point for most of the people going away from escaping this area from the famine. And Derry had the ships going to the UK centres, to Glasgow, to Liverpool, to Australia, to the west of Scotland, and also to America, to the eastern seaboard in America. And most of the local audience will know this place. This is Droghid na Nure, which is the Bridge of Tears near Muckish, where the families came with the relatives who were all leaving because they knew they would never see them again, and that was like your Irish wake. And this is the memorial in Derry on the quayside to the famine victims who left on the coffin ships. And there are on the left hand side. If you're ever in Derry, you can look at this on the quay. They took old railway bunkers from the railways that were lifted there that took the people to the ships, and they made that into the memorial. And then they've got the bronze statue as well of the family and the wee girls sort of waving bye-bye to people. All very emotive. So the site of immigration, agricultural trading led to massive population shifts between Donegal and Derry. This is one of the old photos of the cattle fairs, and people, I think especially in a more urban population, will think, well, that was just animals moving back and forwards. But no, it wasn't, because the people were moving the animals back and forward. And don't forget as well that you had the trade not only in animals but also in people, where you had young girls and boys being sent off from their families who couldn't support them to work in big farms and work in big houses. And so a lot of those people then stayed in Derry or stayed in the nearby area, settled down, and then had families themselves. And then the third major area, or the major cause of immigration from Donegal to Derry, was the shirt factories. And this is the shirt factory mural that's in Derry. And at one time, in the 1920s, there were 44 shirt factories in Derry working. That employed 8,000 women in a population of 40,000. Isn't that amazing? That's such a high proportion of people who were working in the shirt factories. Of course, in a population that probably had employment only of about 10,000 people. So that was where the majority of the population were working, and you had a lot of girls coming from rural areas in Donegal. Again, very little chance of employment, going into Derry, going out to the dances on a Friday or Saturday night, meeting a local guy and staying there. And it was at one stage all the royalty, all the businessmen in the City of London all wore Derry shirts. There's one factory left, it's a wee artisan place, so Google Derry shirts and try and get your shirts locally. So the average age of onset of T60A is about 60. But as we said, as Emer said, early autonomic symptoms are really the big red flag from my point of view, and a lot of them nearly everybody will get cardiac involvement at some stage. I'll just skip through this because I know a lot of the other speakers will be speaking about this. But what I do is I look at obviously the history, the ECG or the tracing, the echo or the ultrasound. If you're seeing somebody with a lot thickening of the heart muscle that you're not expecting, we would expect to see thickening of the heart muscle in patients who've got high blood pressure or who've got aortic stenosis or narrowing of one of their valves. You really don't expect to see it otherwise, apart from genetic conditions. And then a lot of these patients will end up going to Enniskillen to my colleague Dr. Monica Monaghan to get an MRI study, which is very, very helpful and has really, really helped us to move diagnoses on. And ultimately then we try and get DPD scanning. I've struggled in Derry to get funding for DPD scanning, or certainly funding. I had started and we did 5 cases, and then I was told we didn't have funding, so I was very, very demoralised. But I'll channel a bit of Rosaline's energy and we'll try and get it up and running again. So how do we improve diagnosis? Well, you can't be what you can't see. You have to think about these things. If you don't think about it, you're going to miss it, sort of from the medical point of view. Differentials of left ventricular hypertrophy are where the heart muscle's thickening, especially if your tracings of the heart don't look very tall. That's a real something's going on. Low threshold for DPD scanning in particular, and the MRI testing. And then we will do other tests to make sure that it's TTR amyloid that you have rather than AL amyloid. And one thing I wanted to say is I remember having a chat to Professor Gilmore about us trying to deliver a more hub and spoke type model between Altnagelvin and the NAC, where patients didn't have to make that journey, because we have a lot of patients making that journey who are in no fit state to be making the journey to London. And we were trying to get this set up, and everywhere I looked there were barriers, and you can't do this virtually, you can't do that. COVID happened, and overnight we could do it, you know. So things change. Somebody said to me, changes occur in healthcare at a snail's pace. And I said, well, yeah, they do if the snail's moving through hot tar. That's how they move in healthcare. But sometimes you get a wee flurry forward. And I think we've got a great opportunity post-COVID to use the good things that have come out of COVID and to try and really, really run with them and really, really work with them. So my wish list, it's going to seem amazing to the patients here, but I couldn't tell you how many patients come to Altnagelvin with amyloidosis. And the reason that I can't tell you is because some of them come to the gastroenterologist, some of them come to the cardiologist, some of them come to the neurologist, some of them come to the kidney guys, to the nephrologist. Eventually they'll sometimes like Emer's mum come to 5 or 6 or 7 people before they get an actual diagnosis. I hope locally we've really tried to bring amyloid higher up the diagnosis list, so I do hope locally that is better now than it would have been. And a lot of my colleagues would come to me about cases, non-cardiac cases, and do you think could this be amyloid? So it is higher up the list of differentials, but we need a registry. I need DPD re-established and funding. We've got very, very good links with NAC and with I worked with Professor Coyne on the pathways for the south of Ireland as well, for the Republic. Genetic testing locally. Dr. Gillian Ray, who's one of my genetic colleagues in the Belfast Trust, she's now been given funding to try and improve genetic testing locally, so the patients won't have to go to NAC for genetic testing. So that is, if that gets off the ground, that'll be a big improvement for everything. There's no point in diagnosing patients if we can't do anything for you. So getting more confidence and being able to use the new medications and knowing what to do or what medication to give. I think we've all got a lot better at that over the last few years. Now, I'm all of these things in any one day, so I don't know where you would put yourself. When I heard DPD had been funding, I was very much on the bottom right-hand corner, I can tell you. But I'm so pleased to be here today. I'm so pleased to meet many of you, and I'm very, very grateful to Rosaleen for giving me this platform. Thank you.